Hello everyone, welcome to DM Neurology ADC. So today this is the second session of the stroke modules in the Fine Neurophilia Quick Revision series.
We'll go to the topic proper of stroke, in which my question would be, what is the definition of TAA? Definition actually it is 24 hours. And next question is, what is the approximate risk of stroke in a patient 6-year-old presenting with atrial fibrillation, hypertension, diabetes, and history of TAA? So in a patient with history of TAA, how do you predict whether the patient will develop a recurrent stroke? So is there any method? Actually, it is through a CHAD-VASc score. You need to know some score. Example, for a patient with atrial fibrillation developing TAA, whether the stroke will occur in the recent 1 year period. The score is actually previously it was the CHAD-S2 score. Now, extended version of this is their CHAD-VASc score. And also, if there is no atrial fibrillation alone and TAA alone, we use the ABCD to score. If you see, our patient is actually 76-year-old who is having hypertension and diabetes mellitus and stroke or previous history of thromboembolism. So the score is roughly around 6, and 6 corresponds to about 9.8. So it's roughly around 10, which was given in the option. So how do you treat these patients? So this patient, you found that the patient was having diabetes, hypertension, a 76-year-old patient. He was having a history of TAA. Yes, actually, oral anticoagulant is needed for this patient. And it's actually simple, much simpler than you think. If you have a score of 0, it is low risk of stroke. And if 1, it's moderate. And any score above 1 is a high risk. And according to latest guidelines, even you can, first line therapy is not just alone. The newer direct oral anticoagulants like dabigatran, apixaban, etc., edoxaban, and rivaroxaban, etc., can also be given in this patient. So, which of the following would not receive a point in this status 2 VASc score? So, you just studied the status 2 VASc score, and the next question comes to you is actually try to answer this. You just saw the score, or you must have studied previously. Very evident that only female sex is given a score of 1. Male sex is not mentioned in the scoring system at all. So actually, the answer is actually male sex, and most of you have answered it correctly. And as I told you that you can even give direct oral anticoagulants in this patient if it is a non-dramatic AF in such a patient. So this question usually in the institute exam, what is latest will be asked. As you have seen in the recent AIMS exam, you must have seen, I think newer drug for SMA was asked. Similarly, newer drugs actually you have to keep track of. And in case of stroke, I'll ask you this question. So try to answer this question. So these are some questions which you can answer only if you know. And this will constitute about 10% of your MCQs which are coming in the exams. So as you know, there is negative marking in the exam. Some questions, if you don't know at all, please don't try to guess because it costs you a negative mark. And if you know an answer and if you can rule out options, negate out the options and come to a conclusion, then it's well and good. Otherwise, these questions are kept to pick out the top people. And be careful. It's better to leave such questions if you don't know rather than to answer. The answer is dabigatran. So dabigatran, this is not a new question. Idarazumab. This was a drug. It's a reversal agent which is used to reverse the dabigatran induced side effect, basically bleeding. And the newer one which was approved in May 2018 was andexanet, and it's a factor 10A recombinant structure, and it reverses rivaroxaban, edoxaban, apixaban, betrixaban, fondaparinux, as well as enoxaparin. It does not reverse dabigatran. And as you know, there is a new agent in pipeline which I think will get FDA approval soon, and that is siraparantang. And this is actually, you can consider this as a universal reversal agent because it reverses all direct oral anticoagulants low molecular weight heparin as well as unfractionated heparin. So this you need to know. That is why it is. That is why I told you we have to be aware of the newer, latest developments occurring, especially in the field of stroke as we are dealing with it. And that was regarding. So, which now usual question is, which is the most powerful risk factor of stroke? You think it's in prior stroke, but more than that, it's actually the advancing age, which is the most powerful risk factor for stroke. This is a direct wording I took from, I think, Harrison. And next question would be, you need to be aware of few studies, especially while you are trying to crack the institute exams. It's actually dyslipidemia, it was dealing with. And it emphasizes the fact that high dose statins are need of the hour to reduce the stroke reduction, stroke risk. And if you see, these are the studies. I haven't just gone out and took studies from outside. It's just the studies given in Harrison and some in Bradley. So Sparkle trial was actually dealing with statins, especially atorvastatin, and high dose statin was found to be useful in this study. And some studies like studies on pravastatin are there, simvastatin, and progress study dealt with perindopril and indapamide. And this is actually hypertension study, and this is about a study on stroke and the probants, maybe and the siblings, especially. The following is a false statement. Actually, the false statement here is that the intima is actually single layer of smooth muscles, which helps in inhibition of coagulation and thrombosis. That is why your blood vessels doesn't get clogged. And you may wrongly think that this is the right answer, but actually intracranial arteries lack the external elastic lamina. And usually the arteries are 3-layered only. So what is the importance of this question? Because I thought this question would be asked just because of the reason that if you see, external elastic lamina actually forms the extracranial, is present only in the extracranial artery and absent in the intracranial artery. The importance is that is one of the reasons why there is more intracranial aneurysm rather than extracranial aneurysms in patients, right? Because light shear stress or light dissection like thing will produce an aneurysm, that is the outpoaching from the artery. That is an outpoaching which occurs, and it can further cause subarachnoid hemorrhage due to bleeding of the rupture of these arteries. And now, this is a straightforward question from the text. What is the normal cerebral blood flow in the adult brain? Normal cerebral blood flow in the adult brain. And the answer is actually 50 to 55 ml of ml per 100 milligram per minute. So the normal blood flow is actually 50 to 55. And as you know, if the blood flow reduces to less than 18, the limit, this is actually the threshold of electrical failure. So once the electrical activity doesn't occur, the functionality is lost. So you get hemiplegia even if the blood flow goes below 18. And complete loss of the membrane, that is all the ATP and all are lost, and the cell is about to die if there is this membrane failure, which occurs below 8 ml. So these are two numbers which we have to remember, because these are numbers which will be constantly asked, because these are numbers which we need to see, especially while trying to treat the patient with a stroke. Because we have the latest cerebral perfusion studies which look at the cerebral blood volume, cerebral perfusion pressure, etc. And these numbers are very important because of that. And that is the clinical, clinically, the examiner who is setting the question will be prone to think that this question is important when they see the Harrison textbook or Bradley textbook. But you may think that these numbers are not necessary. And so next question similarly would be, so ischemic penumbra, you must have heard by now that ischemic penumbra is very important. This is the area of misery perfusion, which we plan to save in every stroke patient with the recent thrombolysis, the thrombectomy, and increase the thrombectomy time to around 24 hours with the latest DAWN and the Diffuse 3 trial, is based on saving this misery perfusion area, otherwise called as penumbra. So this is actually functionally silent, as we said, because of the electrical silence which is occurring. Actually, this is a area represented by this, actually 8 to 18. So as you said, as this is a thrombus which is occluding the artery, and this area has already undergone infarction. And this is the area which we tell as the penumbra region, the area with mystery perfusion. And as you know, this surrounding area is beyond the penumbra is the area of oligemia. And this penumbra and oligemic region are maintained. It is yet to get affected because of this collateral flow. This collateral flow may be due to a nearby branch or may be due to the leptomeningeal vessels. This is actually the core, and this is the penumbra we are talking. Initially, in the acute stage, this core will be small and the penumbra will be large. And by the time, as time increases, time goes on, the penumbra is encroached by the core. And by about 24 hours, if there is adequate collaterals, by about 24 hours, the core is completely surrounding the penumbra and there is no tissue which can be salvaged. So based on this study of penumbra collateral circulation, we have come up with the fact that usual previous window period was 3 hours initially. We extended it to 4.5 for thrombolysis, and for thrombectomy it was 6 hours, extended to 8. Then now it is then with the diffuse 3 to 16 hours. And now with the latest DAWN trial, it is increased to about 24 hours. This is CT brain of a patient who presented with right side weakness. So this, as you see, this was the initial CT which was taken. And then after 10 days, the CT was repeated. You cannot find anything wrong in the CT. So what do you think it is happening to the patient? Patient completely recovered, or is something happening in this patient? So I'm sure you have seen the CT. My question would be, was it actually cerebritis occurring in the patient? Or is the CT actually not the original CT? It's not belongs to the same person. And was the CT dates misplaced or misnumbered? Or was it an edema which had now reduced? Or the answer is none of them. Okay, I'll tell you that this patient didn't have cerebritis because we didn't give any antibiotics to this patient. And definitely we cross-checked for any patient with a CT brain when the dates were taken, because it could be easily, it can easily mislead you. Because an initial CT when a patient comes with acute ischemic stroke would be perfectly normal before the early signs of CT set in. And also it is not the same patient CT. And edema, if which had of a lesion which has reduced, then the next CT should have shown some portion of the lesion as such. So the answer for this one is actually none of the above. Why I'll tell you that. Before that, I'll just show you what are the early imaging features in CT, which is usually asked. So early imaging features is actually, this one is actually called the dense MCA sign. And what is this called? MCA dot sign. These two are different. MCA dense sign is actually due to the proximal MCA thrombus. M2, the segment in the sylvian region getting affected, produces the MCA dot sign. And this is the obscuration of the lentiform nucleus. This is because of the infarction. There is obscuration of the lentiform nucleus which is seen. That is, there is insular ribbon sign, absence of insular ribbon sign, because collateral flow is not reaching. Flow is not reaching here. This area is getting affected early. That is insular ribbon sign getting affected. And this is actually effacement of sulci. You can see the sulci boundaries on the normal side, and the affected side, because of the edema, it has become effaced. And other one is actually the dense basilar artery sign occurring in posterior circulation. So I'll tell you one thing, that is dense MCA sign. It is actually due to the fresh thrombus. But in case of high hematocrit and calcification, we can actually have a false dense MCA sign. For example, one patient who was an alcoholic came to us, and he was having left-sided symptoms. But if you see the dense, his CT, we found that the patient was having MCA sign over the both sides. And we were wondered because he was having only left-sided symptoms, but MCA dense sign is present in the both sides. And this is just because of the reason that the patient was dehydrated and his hematocrit was high. As you know, he was a chronic alcoholic, and he had a binge of alcohol without taking water. And the problem with this is that being an alcoholic, he had developed seizures and he had developed torch palsy. So high hematocrit is actually can produce false dense MCS sign. Just a point to remember. And the rest of them, I have just noted it down. So what happens in the CT is the normal, how you measure the CT based on the Hornstein unit. And the normal, it will be about 29. And when an infarct occurs, the hyperdensity sets in. Actually, it sets in, it goes down up to 30. In chronic infarct, it will be around less than 20 Hornstein unit. So what was happening in this patient? You saw that the initial CT was normal, and the later CT had near normalized. This doesn't mean that the patient had become normal or the CT has corrected out. But some people may complain that you have wrongly treated the patient. It was not an actual stroke. You have missed something and all. So this is actually an artifact, just for your knowledge, that is called a CT fogging phenomenon. That is the transient return of the incortical cortex to the normal, which occurs due to multiple reasons. And the best way to differentiate, if you are in a very high confusion, like somebody is so much arguing that this is not actually an infarct we have wrongly treated, you can easily do a CT contrast, which shows mild enhancement in the region. MRI definitely helps. And it does not represent any recovery, but it's just an infarct. So actually, I'll tell so if you go and try to buy a Puma shoes, and if you are not that careful, you may end up with even a coma shoes or a coma pattern. So that is regarding stroke mimics. The stroke mimics actually are things which trick us into thinking that it's a stroke. And as you know, stroke is an emergency, and a patient presenting to the casualty with the features of stroke, we don't have much time to rule out whether it's actual stroke or not. And I use the mnemonic usually vitamins, and the most important stroke mimic would be hypoglycemia you have to look out for. That is why in the AHA guidelines, only investigation you should do before going for thrombolysis in the AHA guidelines is to do an RBS of the patient, GRBS of the patient. Rest, even ECG, prop eye, other investigations like X-ray, etc., apart from the CT, is just the RBS we have to see. Also, we have to make sure that the patient was not having seizures, because it could be just a torch palsy, and we think that we may thrombolyze the patient. So the important thing is that if such a stroke mimic comes to you within 4.5 hours, you're strongly sure it's a stroke, you have thrombolyzed the patient. Is it something wrong? Except for this bleeding, which will be evident in the CT. Most other things, the latest ASA guidelines, the AHA guidelines in 2018 say it is reasonable to thrombolyze the patient because they haven't found much of mortality or morbidity because the patient was thrombolyzed and it was a stroke. And I had even had patients who was referred as interesting case of stroke, a funny case of stroke, and it turned out to be GBS. And if you know that vestibular syndromes are notorious to present as like PPPV, etc., can even present as a posterior circulation stroke. And intoxication as in carbon monoxide poison. So that is regarding stroke mimics. The other diseases which mimic stroke. But there is another entity. What do you see here actually? I don't know whether you can make out. It's pretty clear because it is camouflage. You cannot see it properly. All chameleons are not green. So these are actually stroke chameleons. These are actual stroke, which trick you into thinking that it's not actually stroke and it's something else. And the patient remains untreated even if he presents within the window period. For example, in case of bilateral thalamic stroke, as we have already discussed, artery of Percheron infarct can produce as a global amnesia. And sometimes limb shaking TA, that is, it will have a tonic-clonic movements that is due to a transient ischemic attack occurring, and it can be mistaken for a focal epilepsy. And also to know that cortical stroke, example, alcoholic coming with difficulty in lifting his wrist, you may think that it is actually a Saturday night palsy and the radial nerve involvement and all, but it could be even a stroke, cortical stroke in the hand knob area. That is small area within the cortex which get affected, results in the distal arm weakness. Also bilateral occipital strokes results in confusion and delirium. This is actually the name for the balance syndrome, which occurs, which causes much confusion. So recently, one case was there, admitted in psychiatry for 1 week, and because of sudden onset of behavioral changes post-COVID, and we took an MRI and found out that there was a lesion in the Wernicke's area. So that is Wernicke's aphasia. The patient won't be understand anything and just will be talking out incomprehensible stuff, and maybe branded as a psychiatric patient. So that is actually, these are the stroke chameleons, and it's important to differentiate. So what I have done till now is to give you how to approach the questions, how you have to read the textbook, some parts you have to emphasize, or I've tried to cover the stroke basics. Rest of the advanced part I will cover in the next portion. So as you know, the recent Neet was over, multiple institute exams were over, and one of my students, Dr. Shiva Prakash, had helped me compile few questions, and this was actually asked in the recent November 8th. What do you think the answer is? The answer is aspect score. Yes, rightly someone has put in the chat box, aspect score. So do you think aspects is only used for CT? It's actually the Alberta stroke early CT scoring system, and less than 6 is actually a bad score. And now actually they have come up with the MRI based aspect score. So some institutions follow the CT protocol, some follow the MRI protocol, and in some difficult situation we have to go on with the MRI. We may need the MRI, and it's similar to CT. And in MRI protocol, we use the diffusion weighted imaging MRI for the MRI aspect grading. So this is actually the recent JIBMER question. That is the average blood supply to the gray matter of the brain is. So already we have discussed while emphasizing the importance of Penumbra, that blood supply to the gray matter. Gray matter actually includes the neurons and the cell bodies, and they need the maximum supply. And we have discussed that it is roughly around 50. We have discussed that it was 50 to 55. Electrical silence point was 18, and complete absence was, the mechanical failure was actually 8. And in between we had the Penumbra. And here we can see that it is actually 50, roughly 50. And you should know one thing, that is white matter doesn't need that much of blood supply as the gray matter, because gray matter has all the neurons or all the activity, ATP, all occurring mainly in the gray matter. So this question was the recent JIBMER question. One more question. We try to solve this question with the help of a rule of 4 by Gates. So in this question, if you see, the patient had sensory neural hearing loss, 8th nerve nucleus affection, 11th facial palsy, 7th bulbar and below affection, left facial hemisensory loss, hemianesthesia. So that is actually 5th nerve affection. So as you see, all these numbers are not divisors of 12, and these are not medial numbers, medial motor nucleus, just located laterally. So the lesion is in the side of the brainstem, and all these nucleus are within the pons. So this is actually a lateral pontine syndrome. And you know that sensory neural hearing loss is associated usually with the, you shouldn't be misled thinking that it's this sensory neural hearing loss occurs only in ICA. It can also occur in superior cerebellar artery occlusion also. This is given in branding. And also you should, at this point of time, you should think of other neurological conditions which presents with hearing loss, etc. For example, Kennedy's disease, etc. So this question was asked in the NIMHANS previous session, not the recent one, the previous one. So the anatomical location of lesions causing prosopagnosia. We discussed prosopagnosia in large. So that was actually, if somebody remembers, it's actually Broadman area 37. Actually, Broadman area 37 corresponds to fusiform gyrus. Just revising, angular gyrus is 39. This Heschel gyrus would be 41 and 42. That is auditory. This corresponds with apraxia and alexia. Inferior frontal gyrus with the lower portion. It could include 44, 45. That is the Broca's area, and even 46. So that is the importance. So which is not an early CT sign of stroke? It's a comparatively easy question which was asked in last enhance. Whether it's empty delta sign, sulcal effacement, loss of gray white differentiation, or Sylvian dot sign. Sylvian dot sign is otherwise our NCA dot sign, which is occurring due to the M2 thromboembolism. Sulcal effacement we have described. Empty delta sign is actually seen in CVT. All must be aware. But most like such questions could be asked further. So that was regarding the topics, basics of stroke. So hot topics of stroke will be coming in the next chapter, next episode, that is next module. And I urge you all to read these three starting from today before the next module. And I would like to have a feedback. Thank you. All feedbacks are welcome. So hope you have benefited with this effort.